Welcome back to Clinical History in English. Today's topic is pleuritic chest pain. Imagine you are working in the accident and emergency department and you are asked to clerk in or take a history from an 18-year-old male with chest pain. You take a history from the patient and record the following in the patient's notes. Presenting complaint, chest pain. History of the presenting complaint. Now, when we're talking about pain, we can use this helpful acronym Socrates. The S stands for sight. Our patient describes a left-sided lateral chest pain. O for onset. What was the patient doing when it started? Our patient describes a sudden onset while on a break at work. C is for character. Our patient describes a pain that is sharp and stabbing in nature. Stabbing like a knife, coming and going. Okay. R is for radiation. And our patient denies any radiation. A is for associated features. Is the pain associated with anything else? Our patient describes associated shortness of breath. Timing, when did it all start? Our patient says it started 4 hours ago. Remember, it came on suddenly. And E is for exacerbating or alleviating factors. And in this case, the patient describes that it is worse on inspiration. There are no alleviating factors. And S is for severity. How severe is the pain out of 10? And our patient gives it a 6 out of 10. Our patient denies recent history of travel or immobilization. He has not had any fever or cough. He denies calf pain or leg swelling. And he reports feeling otherwise well. The pain came on suddenly and it was a surprise for him. It came, as we say in English, out of the blue. Out of the blue means with no pre-warning, no warning. In terms of his past medical history, he has asthma, which is well controlled with his inhalers. He has had no previous hospital admissions for asthma, and he has never required intubation or ventilation. There is nil else of note. In terms of his drug history, he has no known drug allergies, which in writing we can abbreviate to NKDA. He uses a serotype inhaler, which he takes 2 puffs twice daily. BD is the Latin for twice daily. We use these Latin symbols in English. And he also has a Ventolin inhaler, which he uses PRM, which again is Latin, and it really just means on demand or as needed. In terms of his social history, he's a trainee mechanic and is independent in all his activities of daily living, or ADLs. He lives with his parents. He carries out physical work without difficulty. He's a smoker of a quarter of a packet a day, 5 cigarettes a day, and he drinks 4 pints of beer in the pub at the weekend. He denies recreational drug use. So at this point, what are we thinking in terms of differential diagnoses? Pulmonary embolism, or PE, is a possibility. Pneumothorax, also a strong possibility. But it could be something more benign, like musculoskeletal pain. So we continue assessing this patient. We move on to take his observations. We note that his heart rate is 105 beats per minute, so he's slightly tachycardic. His respiratory rate is 20 breaths per minute, so he's working a bit more with his breathing. His blood pressure, or BP, is 114 over 82, and his saturations, or SATs, are 97% on room air. On examination, just inspecting the patient, he appears to be tachypneic. There's a lot of letters in that word in English, especially in the British spelling, which I used, but the pronunciation is much more straightforward. Tachynic. He's showing short, shallow breathing. So his breathing's not deep, he's taking shallow breaths. No use, though, of accessory muscles. His pulse is regular, but slightly tachy, as we saw on the observations. And his heart sounds, you can hear 1 and 2, and there's no added sounds. On examination of his chest, there's no tenderness on palpation. So that was relevant for one of our possible differentials. Air entry is reduced in the lower left bass, and there is hyperresonance to percussion in the left lower bass. There's no wheeze or crepitations. In terms of his abdomen, it's soft, non-tender, no masses, and lower limbs, there's no edema. Note the British spelling, OE. No edema, no calf tenderness or swelling. So our working diagnosis or impression is that of pneumothorax. Pneumothorax, again, lots of letters. You can ignore the P and the E and just think pneumothorax. Okay. So let's have a little look at his chest x-ray. So this is an anterior-posterior chest x-ray. And we can see on the left side, there's a lack of lung markings, so a loss or absence or lack of lung markings on the left. So it confirms our diagnosis. So what's the management? So a chest drain is inserted and his pneumothorax resolves. The patient will be considered for pleurodesis if there are further episodes. Pleurodesis if there are further episodes. And that's the end of our brief case of pleuritic chest pain. So let's have a little look at some of the words that are more complicated in terms of pronunciation or spelling. So we have here pleuritic, pleuritic. Again, ignore some of the letters. Ignore that E and just think of the U, pleuritic. Onset, onset. This is a really useful word. The beginning of a symptom. When did it start? What was the patient doing? The onset. Radiation, radiation. In a pain history, that's a really key question. And it's in English, radiation, not irradiation, which is, gamma waves and radiotherapy type of treatments. Then we have here cough, cough. Again, half the letters do not represent the actual sound of the word. Think of it as a COF, cough, cough. Now with my British accent, my English accent, I would pronounce the next word intubation, intubation. So the same sound that I use in the word Tuesday, intubation. If I was from the United States, it would be intubation. With a British accent, intubation. And then we have our diagnosis for this case, which was pneumothorax, pneumothorax. And remember, our patient was slightly tachynic, tachynic. And if he has further episodes, or if it hadn't resolved well, we would have considered this patient for pleurodesis, pleurodesis. Hopefully you've managed to pronounce those all correctly and it's stuck in your head. And just a little quiz on some of the abbreviations we saw this time. NKDA, what does that stand for? No known drug allergies. No known drug allergies. BD, it's Latin and we use it to mean twice daily, twice daily. We would use that in speech as well. So we might say the patient's taking Seretide BD, 2 puffs BD. And then PRN, again, we use that in speech as well. The patient is using his Ventolin inhaler PRN, and that means as needed, as required. ADLs, do you remember? Activities of daily living, activities of daily living. BP, that's one we talk about all the time, isn't it? BP, blood pressure. blood pressure. HR, heart rate. And PE, another common abbreviation that we use a lot, PE, pulmonary embolism. Right, so that's all for this time. If you like this video, please give us a thumbs up. If you have any questions or comments or feedback, feel free to drop us a line in the comments. And you can also follow us and interact on Facebook and Instagram at Clinical History. That's all for this time. Take care. Bye.